Good morning, everybody. Today, our topic is anesthesia. Let's start from the first part, preoperative evaluation and preposition. I'm Sen Mei Zhu. You can call me Susan from the First Athletic Hospital, Zhejiang University. As we know, long ago we have no anesthesia, and the patient will be performed surgery in the pain condition. It's very terrible, I think. And pharmacologically induced visible and status of amnesia, analgesia, loss of responsiveness, loss of reflexes, and so on. Lets the surgery goes easy. And we say the start of anesthesia is in 1846. The first publicly performed at Massachusetts General Hospital on Friday by Dr. Morton. And we say this is very great contribution. And the modern practice of anesthesiologists includes preoperative evaluation and optimization of the patient's medical condition prior to surgery, and intraoperative management for adult or pediatric patients undergoing regional or general anesthesia or local anesthesia without sedation. And the second is post-operative care in PICU. And the third one is care of patients with acute or chronic pain problems. And the fourth is clinical management of CPR. And another one, for example, evaluation of respiratory disorders and give some therapy or supervision other medical personnel involved in anesthesia. And also we also have research works. And nowadays, the phase of surgery is changing. As we know, 70% of patients are outpatients, or sometimes maybe just the same day admit surgeries in some hospital. And the patient's average age also increasing. And also we can do most complex or surgery, and some patients undergoing surgery maybe with a severe coexisting disease. So nowadays it's a very challengeable for the anesthesiologist. We say anesthesia care, we have three phases. We call 3 Ps, and that is preoperative care, that's planning, and intraoperative management. So just we providing different types of anesthesia, for example, regional anesthesia or general anesthesia, and post-operative anesthesia care. And the goals of preoperative evaluation is just to evaluate a patient, to assess appropriateness of a patient's condition, and to optimize a patient's condition prior to anesthesia and surgery to ensure the safety of patients, and to determine the options of anesthetic management for individual surgical procedures, and also to evaluate airway anatomies and obtaining the informed consent for anesthetic plan, anesthesia plan, we say. And through the preoperative evaluation, we can establish some kind of confidence between doctors and patients. This is the preoperative evaluation flow chart. We say first we should confirm the procedure of the surgery and the diagnosis, and then we should check the the current medicine therapy of the patient. And then we should review the history of the patient and the present illness, and we give the physical examination, and we should make sure the physical status of classification of the patient, and then we make the anesthesia plan. When we do the preoperative evaluation, we should make sure if the patient if this surgery is effective or emergent, if the surgery is life-threatening, or what is the surgical location. So we can evaluate the surgical risks, or we can maybe give some plan or some interference. And then we should check the current medicine therapy of the patient, because as we know, some potential drug interactions can cause adverse effects. For example, some antibiotics, aspirin. Aspirin, if the patient takes aspirin, and maybe it causes bleeding in the operative stage, and so on. We must make sure what kind of medicines the patient has taken at the moment. And the next step is to review the history of the patient. For example, past anesthesia, and past surgical history, or past medical history of medication, and the family or social history. For example, if you wanted to know if the patient took some anesthesia steps in his history, we can give some questions. For example, have you ever had problems with anesthesia, or did you have bad experience with anesthesia, or any adverse reactions to anesthesia in family members? And through these questions, we can know we can get some very useful information for the history of the patient. And as we know, because some anesthesia steps can cause some adverse effects. For example, allergic reactions. Patient, if have some allergic history, he or she may be suffer from allergic reaction, or some, for example, myalgia or jaundice or headache, something like that. So we must make sure if the patient had taken some kind of anesthesia, or if he or she got some adverse reaction. And for the past surgical, it's the same. We should know. We should get some information for the past surgical of the patients, or some past medication history, and also some family information. For example, any members has significant medical problems, or did the patient use some drugs, and etc. And after we go through the past history, or go through the past history of the patient, we should check the present illness of the patient. And another, for example, the laboratory test or imaging studies, for example, chest X-ray, CT, MRI, and so on. And then we should give some physical examination. For example, what is the mental status of the patient, and how is the peripheral sensory and the motor function of the patient, and what kind of status of function, for example, cardiac or pulmonary function of the patient, and also we should check the airway of the anatomy of the patient. For example, mouth opening degree usually should be 6 to 8 centimeter, and cervical or spinal morbidities, or some, for example, silomental distance, and so on. And make sure if the patient exhibits difficult airway. This is a Mampton classification. The Mampton classification related the tongue size to pharyngeal size. This test is performed with the patient in the sitting position and the head held in a neutral position, a mouth wide open and the tongue protruding to the maximum. The subsequent classification is signed according to the pharyngeal structures that are visible. Class 1, we say the visualization of the soft palate, forceps, and the uvula, anterior and posterior pillars. And class 2, we cannot see the anterior and posterior pillars. We just can see the soft palate, forceps, and the uvula. And class 3, we just can see we can see the soft palate and the basis of uvula. And class 2, we say we cannot see the soft palate. If the patient Mampton classification class 1 and class 2, we say maybe it is easy airway, or maybe there is no difficult airway. And if the patient Mampton classification is class 3 or class 4, and maybe the patient exhibits potential difficult airway, we should make a very good preposition to the intubation. And we also should evaluate the cardiac vascular risk. We say we can classify 3 degrees of the cardiovascular risks. Major is, we say, unstable, just four kind of situation. One is unstable coronary syndrome, and the second, and the decompensated congestive heart failure, and sudden and significant arrhythmias, and the fourth is severe valvular disease. If a patient has this kind disease, we should delay the elective surgery. And the intermediate is mild angina pectoris and previous myocardial infarction by history of pathologic waves. Or third is compensated and previous congestive heart failure. And the next one is diabetes mellitus. And we say minor is elderly patients with advanced age, or abnormal electrocardiogram, or rhythm other than sinus, or the low function capacity, or history of maybe stroke, and uncontrolled systemic hypertension. After we go through the history and examination and so on, we should give patient an ASA physical status classification. And according the ASA, when the ASA's classification has six degrees. One is healthy patient, and the second one is mild systemic disease with no functional limitation, and the third one is severe systemic disease results in functional limitations. And fourth one is severe systemic disease that is constant threat to life. And fifth one is moribund, not to survive without surgery. And sixth, brain dead organ donor. And E is represent emergency surgery. We know the classification higher, and the danger of the surgery is higher. And after we check the patient, we evaluate the patient's salary, and we should make the anesthesia plan. For example, we should make sure what kind of anesthesia, what type of anesthesia we will deliver, and usually many factors will influence the choice of anesthesia techniques. And for example, the coexisting disease and the site of the surgery. If the patient is underwent the brain surgery, we should give general anesthesia, for example. And the position during the surgery and elective or emergency surgery, and so on. And these factors all can influence us to choose the type of anesthesia. And if the patient, we say, if the surgery can make us choose several kind of anesthesia for patients, and at that time, I think the patient's willingness and so on can make us to choose a type of anesthesia. General anesthesia is total loss of consciousness and the need to kill intubation, and we say the patient first lost consciousness, and after surgery and can emergence, and then we can extubate patient and send them to the PICU. And the regional anesthesia or local anesthesia, the patient is awake. Sometimes we can sedate it, or sometimes without sedation. And so we say if patient is candidate for multiple anesthesia techniques, choice of anesthesia can be based on patient's preference, provider's experience, or availability of the resources. Three factors. This is the evaluation of the patient pre-operative stage. And next we talk preposition of anesthesia. When we do the preposition of anesthesia, we should discuss with the patient, and we should give medication to the patient, and also we should get the consent from the patient. And then we should, before we give the anesthesia types or anesthesia techniques, we should preposition something in the operating theater. This is discussion with the patient. We can discussion with the patient, tell them the anesthesia plan, anesthesia risks, and tell them the anesthesia maybe adverse effect to the patient. For example, sometimes may nausea or vomiting after the operation, and sometimes we may be some more severe complication after operation. And also we can discuss more, for example, the time of the starting the surgery, and the antecedent duration of surgery, or some recovery in the PICU, or maybe some post-operation discomfort, and the method available for some treatment. You know, before the surgery, almost every patient is very anxious. So we should talk to them, and we should that patient be confident with you, and also visit by anesthesiologist is the very best way to live and enjoy it. Anxiety relief can also be achieved from the medication. Sometimes we can give metazolone or some or other drugs. We say metazolone is the most commonly used. Before operation, we can use 1 to 5 milligram and from oral, usually from oral. And the other goals of the medication maybe sometimes we should give the medication for analgesia, for increasing gastric fluid pH, for sometimes for prophylaxis, or for sometimes decrease in anesthetic requirements. And medicines commonly used as below: benzodiazepines, opiates, and antihistamines, or some H2 blockers, sometimes antacids or anticholinergics, and sometimes we can give alpha-2 antagonists or barbiturates. And the benzodiazepines, we say, is almost every patient gets, and the drug can have some effects. For example, enhance the effect of neurotransmitter, and also sometimes can produce anxiolysis or sedation and hypnosis. But many, as we know, many drugs have some side effects, and the benzodiazepines is also have some side effects. For example, respiratory depression and short-term cognitive effects of withdrawal dependency, and so on. And some patients we cannot give sedative drugs. For example, if a patient with COPD or with bronchitis or with sleep apnea, and also these patients we cannot give sedative medication pre-operative stage. And for cautions, sometimes in patients with personality disorders and mental retardations, and also we should avoid drug interaction with alcohol, barbiturates, and some opiates. We should balance if we give this kind of drugs. And for a patient with pregnancy, we also should be very, very cautious, because if you give this kind of drugs, maybe have some potential birth defects of the infants, and sometimes newborn we maybe sometimes withdraw the symptoms, for example, tremors and hypotonia, something like that. So have some kind of dangers. And benzodiazepines have short-acting or intermediate-acting or long-acting and different different duration, and the action duration is different, and you can choose different type of medication according to the individual patients. And H2 antagonist for patients with increased risk of pulmonary aspiration and we can give H2 antagonists and also antihistamines occasionally used preoperative stage to prophylaxis against allergy and infection. Okay, now we go through the review of the history or system of the patients, and we just discuss with the patient, get the consent from the patient, and already made the management strategy for the individual patient. And now we should, if we before the start of the anesthesia, one step we should do, that is preposition in the OR, in the operating theater. Routine preposition, we say regardless of anesthesia types, we should select it. That means no matter how small the anesthesia is, you also should give the routine preposition. For example, anesthetic machine, some drugs, or some equipment. This is the anesthesia machine. When we check the anesthesia machine, we should check the anesthesia anesthetic breathing system, or we should test ventilation, check the breathing system valves, and also we should calibrate oxygen analyze and confirm suction system. It's very important. We should confirm the suction system, and also we should check soda lamps for color changes. We should check the liquid level of the vasorizers, or we should check flow meters, and we should check monitors, especially the alarm ranges of the monitors. We should make sure the alarm of the monitors is open. And this is the drugs we should prepare before our anesthesia started. A list of the drugs, for example, we should prepare local anesthetics, for example, lidocaine, and for pain relief, or for the induction. And we should prepare the induction drugs, for example, propofol, etrovidate, or cypental, and some opiate, for example, morphine or fentanyl, and some anticholinergics, some mimetics, or so on. And also we should prepare some equipment, laryngoscope or gyroscope for the intubation, for the endotracheal tubers. And for different patients, we choose different size of the tracheal intubations according to the patient's age, patient's weight, something like that. And also we should prepare for oral or nasal airways and suction catheters. That's very important to some patients with the respiratory aspiration. And also we should prepare intravenous fluid and connecting tube, and also the intravascular cannulation catheter. And the conclusion is, when we give the preoperative evaluate, we review the flow chart. This is the flow chart. Every steps we should go through, and if the patients go to the preoperative evaluation clinic, sometimes the anesthesiologists go to the ward to review, to go through the history of the patients, to evaluate the condition of the patients. we should give some aspects, for example, history and physical examination, and talk to the patients and get some consent from patient, and last make a very complete anesthesia plan, and give a very good preparation for very good preparation in the OR, and then now we can start our anesthesia. Thank you.